The next, we will start the instrument. Dr. Rusrin Bose and Dr. Chiranjeev Das will show you the instrument.
So after this mind-boggling session of head and neck, I'll bring you to a bit of a cool so that you get to know all the instruments that you already know of. Just a few more names and uses in case you have missed out anything. I'll start with the otology instruments first. Let's do the speculum first. So this is a Lempert's. Yeah, this is a Lempert's end oral speculum, and for this you will be asked to hold it in an anatomical position in case you are asked. So for any instrument, see, instruments will come for at least 20 to 30 marks, and they are extremely point scoring. If you are asked to pick up an instrument, always choose something which you know from A to Z, including the name, the uses, the anatomical position that you want to hold it on. The next thing is anything related to it. Like in case they ask you this, you should be knowing about the Lempert's incision. What is a modified Rosen's incision? What is Lempert 1, Lempert 2? Okay, so if you are this actually has two kinds of speculums. One is for the left ear, the other one is for the right ear. So as you can see here, this is for the right ear in a anatomical position. And for the left ear, this limb would have been on the other side. Okay, so what is this? This looks like an oral speculum, but actually this is a Killian's long bladed nasal speculum. Okay, so don't get confused. These might be kept together. You can see a change in shape of the Lempert's and oral speculum where one limb is a bit slanted than the other. Okay. So with these speculums, I come to, there are not many instruments here, but there are three more speculums that you need to know. One is the round steel speculum, which is non-slotted. That is our routine Rosen speculum which we use to do any sort of outdoor procedures, to do a wax suctioning, de-epithelialization of debris, waxy debris. And there's one more black one which has a slot, that is the Tumarkin slotted speculum. That Tumarkin slotted speculum is again used intraoperatively, and that slot is at the entire length of the speculum, which allows us to straighten the external auditory canal as well as infiltrate through the slot. Okay, so as you rotate the speculum, you can keep infiltrating in whichever quadrant you want. The thing that you need to remember here is this speculum should not be touching very hard on the bony surface. One, it will cause trauma. Second, it will cause immense pain if your patient is under local anesthesia. The third kind of speculum that you need to know is another black speculum, which is plastic kind of a fiber, but has a pen. Is there a pen? Which has a beveled edge. So this is again your speculum, and it has a beveled edge like this. So this is an angulation with the tympanic membrane, and this is known as the Shia speculum. So Shia invented himself because he wanted to do a stapes surgery, and they are in favor of doing a transcanal approach. Okay, so once you fit in this into the external auditory canal, both your hands are free and you can manipulate it with both the instruments, one hand suction and one hand your instruments. So we are done with the speculums. Now let's come to the retractors. We have only one kind of retractor here, which is the Molleson's self-retaining hemostatic retractor, mastoid retractor. This is the full name, Molleson's self-retaining hemostatic mastoid retractor. And this is available in various prongs, sizes, whether it is 2-prong, 3-prong, and even 4-prong. So the function of this retractor, it retracts away the soft tissue while you are exposing the mastoid cortex, and it crushes the vessels as it is retracted. So it activates the enzymatic clotting factors which help in clotting. There are two more speculum retractors that you should know. Sometimes you would have seen that this part is absolutely plain, like it's completely steel and it's not hollow. That is known as the Plesтер's retractor. Plesтер's mastoid retractor. Ah, it's there, right. This is the Plesтер's mastoid retractor. One blade is steel and the other side has prongs. So this is retracting the soft tissue without causing any trauma. And this is the place where you've already given the incision and maybe in the suprameatal region. Okay. So there's another kind of retractor which is available in all our OTs. I'm sure you would have seen the one with the screws that we don't use anymore. That is called the Jansen's retractor. These are the three things you should know: Jansen, Plester and Mollison. Most likely you'll be asked the Mollison in the exam. Coming on to the micro instruments now. Micro ear instruments, we don't have much. We have only two things which are named. One is the Wolstein's cup forceps. I'll just show you. This. দেখা যাচ্ছে? Very difficult though. নিচে রাখবো দেখো. They know all this, but still. So this is the Wolstein's cup forceps. You know, all of you know the uses to remove the soft tissue from the incus, malleus, around the round window. And you can remember that this cup that is present distally is 0.9 mm. The diameter of the cup is 0.9 mm. That's the only thing you need to remember. And you have one more forceps here. You have micro ear scissors. They are not named after anyone. And you have this crocodile scissors, the crocodile forceps, sorry. It is called the Hartmann alligator forceps. The Hartmann alligator forceps, it's used to deliver cotton pledgets into the ear to remove soft tissue in very micro movements of elevating the tympanic membrane. The next thing that we need to know here is, you know, all the other micro ear instruments, the long ones. We have the Plester's knife, that's the Plester's flag knife, or commonly called as the D knife. And there's one more, which is the Rosen circular knife. It may be perforated or non-perforated. So it's known as the Rosen circular knife. Both of them are used to elevate the tympanomeatal flap. And there's one more instrument which we it's the Beals elevator, Beale'', or the Rugen. It's called the Beals elevator. Now this Beals elevator, interestingly, is actually a microbone elevator. So you can elevate periosteum from above the head of the malleus. You can, in the anterior part of the, where you are elevating the anterior tympanomeatal flap, this elevator is of much help. The remaining ones are the curved needles, the right angle picks. They are not in anybody's names that I know of. तुम की जानो? कोनो नाम तो नहीं. And you have the sickle knife. It's a micro sickle knife. Okay. So your micro ear instruments are done. Now we will just quickly go through the stapes instruments. Stapes, you have two kinds of perforators. So if you look closely, you have two perforators here. One is not guarded, it's absolutely straight, and the other one is a bit guarded here. So having a guard is of a bit of an advantage if you are a beginner. It really doesn't matter if there is no guard. The guard helps in, once your perforator perforates the footplate of the stapes, it doesn't suddenly go into the vestibule. It helps in preventing a floating footplate also. But if you have acquired an expertise, you are good to go through with a non-guarded perforator as well. Okay. So perforators are available in various sizes. They are available in from zero point 0.4 to 0.8. We have 0.4, 0.5, 0.6, 0.7 and 0.8. Okay, so according to your size of the piston shaft, the diameter of the piston shaft, you can use your perforator. You should use one size above your diameter of your piston shaft. If your diameter that you are using is 0.6, you should at least use a 0.7 perforator. If you are using 0.5, you should at least use a 0.6 or 0.7. Okay. The next is the house measuring curette. The house measuring depth gauge. All of you know that the house measuring depth gauge has 3 points. This is an instrument, it's a depth gauge instrument which measures the distance of the foot plate from the above of the foot plate to the incus lower border. Now, we need to know that there are 3 markings here, 1, 2 and 3. So, the first marking, which is actually proximal, that means the first, when you hold this instrument upright, the first, that is at 3.75 centimeters. Okay. The next one is at 4.25, 3.75, 4 and 4.25. So when you are measuring it from the incus up to the foot plate of the stapes, you have to add 0.5. Can anybody tell me why we have to add 0.5? Are you all sleeping? I would like to have some answer so that I know you are awake. Yes. So the average the average foot plate thickness is around 0.24 to 0.511. So on an average, we just add 0.5. So 3.7. So if you get it in the first mark is 3.75 plus 0.5, that is 4.25. 4 plus 0.5, that's 4.5, and 4.25 plus 0.5, that is 4.75. Okay, clear about this? So we are done with this. We also have another curette by the name of house. So this is the house micro-ear curette. This is very important to remove the posterior superior overhang bulge. It should be of at least 0.9 mm to 1 centimeter depth, so that you can have a good removal of the bone during curettage. This is it. I'll come over to the tonsil instruments now. So tonsillectomy, as we all know, I would like one of you to just stand up and tell me what is a rose position. We have to be very quick, we are already delayed. তার মানে তোমরা কেউ জানো না, তাই কি? কি আইদার তোমরা সবাই সব কিছু জানো যেটা বলতে চাইছো না, or you don't know, or you're sleeping. বল দাঁড়িয়ে বল। আরে রোজ পজিশন, হ্যাঁ বল, you're telling Atlanto Hospital কি? Yes, that's right. So, and how will you achieve that? All right. So, in a rose position, we have to use this. This is the Boyles-Davis mouth gag. So, which one is Boyles and which one is Davis? The D is Davis. This is Davis. This is the Davis mouth gag. And what is this? Boyle's blade. Okay. So, tongue blade. Now, this has a slot here. Okay. So, the moment it gets a slot, the name changes. The name changes to right. So, now, are you all familiar with how you have to hold this, or should I show you? Does everybody know? Then I'll skip this part. Yes. Now, we're coming to the Druffin's bipod. These are the Druffin's bipod which can be attached at level 2 or level 3 with the Boyle's tongue blade. And this is the Megorans plate. Okay, so these have screws where you can put the Draffen's bipod, fix it. Once you have opened the mouth enough, fix the Draffen's bipod onto these screws at the Megorans plate and fix your position for the tonsil. The next step would be holding the tonsil medially and inwards. And I can't see the Dennis Brown. Yeah. So this is the Dennis Brown tonsil holding forceps. This is the first instrument you need. You hold the tonsil medially and inward and downward to make your incision with a Evans tonsillar knife. Okay, so this is a Evans tonsillar knife and dissector. There's a knife on one side and there's a blunt dissector on the other. Once you have made this incision, you switch over to a serrator or a dissector. Actually, this dissector is named after Molleson's, which has got an anterior pillar retractor on one side and a dissector on the other side. You also have another dissector. It's called by the same name, Molleson's dissector, which is dissecting surfaces on both sides. So you have to dissect out from the tonsillar bed the tonsils, and slowly you can use, what are these? What are these forceps? Was forceps. So they are either tooth or non-tooth. These are the was forceps used for WAUGH. If you are a millennial, you will know, because we had a lot of cricketers by that name before in Australian cricket team. So tooth or non-tooth, you can hold your swab, you can wipe off the blood from there, you can do a soft tissue dissection with these forceps. The next is the Metzenbaum tonsillar scissors. These are the long bladed scissors specially designed for cutting the soft tissues or doing a sharp dissection in the tonsillar bed. So this is known by the name Metzenbaum. Metzenbaum. Okay. The next one is the Negus knot adjuster or pusher. Knot pusher or knot adjuster. Now all of you know that we use this to just slide down our knot and adjust it when we are tying the vessels. And this is, what is this? This is not name. এটার নামটা কি বলো তো, আমি just blank হয়ে গেলাম. It's not Negus, right? I'll just get back to you with this. I just got a blank for this. These are the straight artery forceps and the curved artery forceps. It goes by a name. I'll let you know. No, it's not the Negus. It has some other name. Okay. So I think I have finished all. And this is the Yankauer's suction, metallic suction. Yankauers. This is a metallic suction. The advantages are this is blunt, so this does not cause any trauma. Most of the time suctions are known to cause trauma when you are just suctioning out through a soft tissue bed. Now already there is so much bleeding during tonsils, so this is a good option and it's used only for that reason. I'll hand over the mic to Dr. Chiranjeev. He'll do the rest.
Good afternoon. Hope you are all awake. I will show one by one instrument and you will help me to answer the name of the instruments and use also. Okay. So first instrument, Killian self-retaining nasal speculum, used in operation like septoplasty, submucosal resection of septum. Okay. Next, Tilly's nasal dressing forceps, used to give anterior nasal packing and removal of foreign body from oropharynx. Or next, this one, Yes, angulated. So as use for repair of fractured septum. Okay, and the two blades are similar length, and this one Walsham's used to reduce a fractured nasal bone. There are two prongs, one is longer than the other. The longer prong will be outside or inside the nose? Outside, and it will be covered with a rubber to prevent the injury to skin. Next, no, simple nasal suction cannula. Okay, same. This one, yes, free suction, Freer's elevator, mucoperitoneal elevator. Lux forceps use to remove fracture a part of the fragments of cartilage bones for biopsy, etc. This one, gouge, bayonet shape gouge. This is Tilly's, okay, not Killian. Killian, the shape is U-shaped, blunt, and this is V, and it is sharp. Okay. Mallet. This one. Chisel. What is the difference between chisel and osteotomy? Osteotomy has bevel end on both sides, and chisel had bevel end on one side. Okay. Turbinectomy scissors, Heyman turbinectomy scissors. Olive pointed. Nasal suction cannula, Killian. Okay, the name of the surgeon is Killian, who invented and used for suction in maxillary sinus. Cup curate, cup shaped curate, it is straight. Use, no, it is straight. So it used in ethmoid sinus, ethmoidectomy. And it is also available in more angulated 45 degree, that is used in frontal and maxillary sinus. Okay. Blakesley oil, straight nasal forceps, straight and upturned, 45 degree upturned. Use straight one is used in ethmoidectomy. Okay, and the upturned to remove tissues or bones from the uncinate or maxillary sinus.
Sir, I have one question. Why there is a hole in the tip of the Blakesley forceps?
Yes. Yes. To prevent injury to the soft tissue, to hold that more tissue. Anything else, sir? Ostrom, backbiting forceps. Okay. It is also available in rotating variety. It is not non-rotating here. Straight endoscopic nasal scissor. This one is rotating variety of Heuizer antrum forceps to remove tissues from maxillary antrum. Heuizer, Heuweiser. What is the name of the instrument? Kuhn-Bolger frontal sinus giraffe forceps to remove tissue from frontal recess. Okay, no, not frontal sinus, first frontal recess, and it is side opening. And there is one variety that is anterior posterior opening. Killian's round jaw or bone punch. Use endoscopic endonasal dacryocysto rhinostomy and also to enlarge any bony ostium after Carloillac or any site, other site, to enlarge the bony ostia. These are same things. Yes, in the open. This one. The What is the name of the instrument? Klein-Sasser suspension laryngoscope. And another variety will be anterior commissure, but it is straight. Okay. Why suspension laryngoscope? Why it is called suspension laryngoscope? Because it can be suspended with the help of chest piece. Okay. This is Rickard chest piece with jack. Okay. Esophagoscope. Esophagoscope. Oh, এটা হ্যাঁ তাড়াতাড়ি বল ফোকাস microlaryngeal suction cannula. Next. Upturn cupped microlaryngeal forceps. That is right turn. Then straight cupped forceps for microlaryngeal surgery. Then scissor. Oh, yes. দুটো একসঙ্গে স্কোপ দেখাচ্ছি. Now there are two scopes. Left one is esophagoscope and right one is bronchoscope. Why? What are the differences? Yes, there are markings over esophagoscope. It is oval shaped and it is longer. Okay. And bronchoscope, round. It has ventilating ports over the distal end and it has no markings. Okay. What are the parts? Handle, okay, then shaft, distal end, bevel end, okay, and light carrier port. What are the parts of bronchoscope? What are the ports? This is Fluvrog adapter, okay, the upper one. The right one is light carrier port. Left one is for connecting the respirator, ventilator, okay, tube. And this one is for connecting suction tube. And it is the shaft and with bevel distal end, okay. So why this cap is present? For passing the instrument and make a closed chamber. After passing the instrument, the whole system will be closed system to give ventilation. And you have to tell the size and length of the bronchoscope. Oh, achha, achha. It is 7.5 and 43 centimeter. Okay. So what is it? Which variety? It is adult variety. Okay. And in pediatric variety, what is the size? Minimum size? 2. Starts from 2. Okay. Forceps. This is esophageal suction cannula. Cuff forceps for esophagoscopy. And alligator forceps for esophagoscopy. Okay. Complete. There are other instruments also available in your institutions. These are overall maximum instruments you should know.
During esophagoscopy, holding and how to introduce the esophagoscope, that is also important. You should hold in the left hand. Your right hand will be free. Okay. And the position of the body, that is also important. That means it should be on a line. That means you have to extend, it is not required. Sandbag is not required, just extension. Okay, simple. Another is that bronchoscope, you see the difference, and during bronchoscope introduction, that is, you should ask your anesthetist, just laryngoscopy, do the laryngoscopy, then introduce, go to the vocal cord beyond, then you introduce the bronchoscope.
So yes, you all were asking about the Negus artery forceps. This is the Negus artery, tonsillar artery forceps. It is 6 inches. The hook is at least 6 inches and it has got transverse serrations inside. So the transverse serrations are made because there are 2 reasons for this. One is it causes lesser tissue trauma and it crushes the vessel in the same direction. So the hemostasis is much better. And these are the two forceps which I was talking about. These are named after the surgeon Brickett, Brickett. So these are nothing but again bleeder holding forceps. You can just crush the vessels and tie your sutures around it for hemostasis. These are the ones which were missed out.
Okay. Any questions you can ask? Or the Google form is given. If you any questions, put the questions so that we don't know everything at the present now time. So if you have any doubts, that will clear by the tomorrow by the expert. If any questions. Thank you. Today's session will end now, and tomorrow we will start again at 9 a.m.